thank you for your time. It really is interesting times, and it's a pleasure to spend some time going through some of our experience with you, looking through the step up and decision making, going through oxygen therapy of various forms in the management of the severe hypoxic pneumonias emanating from COVID. I'm quite happy to take questions as we go. This is going to be really very informal, and it's really just looking at the experience that we've had. So the approach that we've taken is really right from the initial presentation from an emergency center or an emergency department perspective, and taking it all the way through into the ambit of critical care. Now, if you're anything like we are down here, we have had quite a lot of reallocations of staff, and this has been to meet the needs in different departments. And so we've had individuals whose knowledge and experience may not be in the management of acute respiratory failure. This is the kind of approach that we have gone through with these individuals to give them a good understanding. So based from the initial assessment on arrival, we make a review of the saturations, and if they are hypoxic on arrival, we will take them through a stepwise approach with regards to supplemental oxygen. We start with the nasal cannula, that's a normal nasal cannula, then stepping up to a 40% face mask, and then onto a rebreather mask. And if that is not successful, we will then do what we refer to as double barreled, where we will place a nasal cannula under a non-rebreather mask. Now, the decision making that we use in going through that process is really dependent on the response of the patient. And here we're looking at three key aspects. We look at the absolute number from a saturation perspective. We look at the respiratory rate and the changes in the respiratory rate. And we look at the patient's work of breathing. So on arrival, if the patient is able to maintain saturations of greater than 93% on room air and a respiratory rate of less than 30, we will trial them without any supplemental oxygen. If they are starting to tire or they demonstrate an increased work of breathing, is when we would commence the baseline nasal cannula oxygen, and then a stepwise approach. If they are not able to maintain sats of greater than 90%, we will then escalate across the various factors at our disposal.
Sorry, Prof, sorry to interrupt. I just want to make sure that, do you have a presentation that you're sharing? Or I just want to make sure.
No.
Okay.
No, I'd said to David, I would be doing this as an informal chat, and I'm quite happy to take questions as we go. I hadn't pushed the wrong button, if that's what you're asking.
That's what I was supposed to make sure. Perfect, thank you very much.
All right, so the question then comes down to, what if the patient has not responded adequately to these baseline installations? And this may be at the initial presentation in an emergency center, or it may be from a ward level where the patient has been admitted for oxygen therapy in a ward by normal face mask. And that's often a difficult decision to answer. It is not only based on the need of the patient, but often it's also based on the available resource. And we know that we do have a critical shortage of critical care beds across the country. And so patients are triaged according to who is going to do best by them. Now, I'm aware that the Critical Care Society published a triage tool. The Western Cape Critical Care Forum has published a significant modification of that tool, and it's what we use in order to determine not only whether a person would qualify for critical care intervention in place of palliative care, but also in what order the individuals would be offered that therapy, should it become available. Now, from a critical care perspective, we always tend to think of intubation, and it's something that we've learned going in, is that whilst we thought that intubation was the way to go, and we've seen from experience abroad that early intubation was trialed and the patients didn't do well. And so we said, well, let's try the opposite, and we go for late intubation. And the difficulty there is often patients are in extremis and they don't do well during the intubation process and are either highly unstable in the period immediately following the intubation or may demise during that process. And so we needed to have something in between. Now, Usha Lala and her colleagues at Tygerberg Hospital started using high flow quite successfully. And we've seen that being rolled out across public facilities within the Western Cape. And it's also being used quite successfully within the private sector. The question becomes, what kind of patient are we going to try? When should we be looking at high flow for patients? And when do we decide that high flow has not worked? In other words, when do we say, we've tried, it hasn't worked, and we need to look at something else? And I'll come on to the adjuncts of non-invasive ventilation in a little while. I think one of the big things that concerned us right from the get-go with regards to high flow nasal oxygen was the potential risk of aerosolization and the potential risk to healthcare workers managing those patients. There have been several papers that have been published in the last few weeks which have successfully demonstrated that that risk is probably not as great as we thought it was, though it is still there, and airborne precautions should be taken when managing these patients. So I'm going to focus on the indications for adults for high flow, in that we do have used it in pediatrics very successfully, and in fact probably the pediatricians have far longer experience with regards to high flow nasal cannulae, and that it has only really emerged into the adult critical care in the last couple of years. Probably the biggest indication, and the one that we're using it for here in this COVID epidemic, is the acute hypoxemic respiratory failure. And we see it mainly from pneumonias, and particularly in the viral pneumonias. In a select group of individuals, you may use it post-extubation in an attempt to bridge them from invasive ventilation onto room air or oxygen, face mask-based oxygen therapy. And there are some that use it as a pre-intubation technique in order to pre-oxygenate. But if I can focus then on the use of high flow in the hypoxic pneumonias, and it's the ones that we are seeing here. And we're seeing patients presenting with profound hypoxias. And to give you an example, we had a patient presenting yesterday to the emergency center, 73 years old, known hypertensive diabetic and morbidly obese, who presented to us with room air saturations of 24%. We went through that stepwise approach with regards to oxygenation. On nasal cannula, she picked up to 32%. On non-rebreather mask, she picked up to 48%. And on the double-barreled oxygen, she leveled out at 68%. Now, the difficulty comes is that where to from here? So this tends to be the kind of case that you would consider for high flow nasal oxygen. And it's really got to do with the ability to actually guarantee the FiO2. Now, if I can just take a step back at this stage and just explain the big difference between normal nasal cannulas and the high flow nasal cannulas. So a normal nasal cannula, you put the cannula into the nose. You run it at anything between 1 and perhaps 8 liters per minute at max. And with that, you are able to increase the FiO2 by about 1 to 2% per liter of oxygen that you are delivering under normal circumstances. The difficulty is that if you've got a patient who's got an increased respiratory rate or an increased minute ventilation, you get a relative dilution of that oxygen that you are applying. And so by giving that low flow nasal oxygen, we're not giving as much oxygen as we think we are. The other difficulty is that if you start cranking up your flows in order to try and match that need, you end up with 2 difficulties. Firstly, it cools the airways quite significantly, which can stimulate inflammation, but also it dries the airways quite successfully. And so you have difficulty with regards to clearance of secretions. And this is where really high flow nasal oxygen has really come into its own. And if you think about it, it's not only high flow, but it is heated and humidified. So it's the big 3 H's: high flow, heated, and humidified. We are able to apply this at high flow, so you do not get that dilutional effect of the oxygen itself that is caused by the patient breathing so fast. But we are also able to provide heated and humidified air. It is generally very well tolerated by patients because a lot of the other techniques are quite claustrophobic for a hypoxic patient to deal with. It does very well with regards to from a nursing perspective, in that the patient is able to eat themselves, they can drink, and they are still able to position themselves because it does not require any sedation. And often these patients do incredibly well on it. So you're probably wanting to know how you go about it. Firstly, you need to get to know the machine. And there are 2 broad machines that are currently in usage from a trade name perspective, but it's just important to get to know the machines in your environment. And if you've got a clinical facilitator at your facility, or what we've done a lot is relied on the product specialists from the equipment companies to come and demonstrate the actual machines. Firstly, so you know where to turn the alarms off, but also on how to tune them in order to achieve what you're trying to achieve. So putting a patient on, you want to really try and get by with your best go at it. And so we tend to start very, very high. We start on maximum flows and we start on 100% FiO2. And the aim initially is to keep them on those high flows, but then to try and get the FiO2 down to below 60% as soon as possible. And if you are not able to do that in a relatively short period of time, you may be heading towards a failure on the high flow nasal oxygen. Now, when I say on max flow, it is dependent on the machine that you've got, in that they run, in adults, we would run anything between 30 and 60 liters per minute on those, and running that at 100% as a start. You need to ensure that the humidification system is working and that the heating system is working. You need to brief the patient that they are going to have something warm and wet strapped to their nose, because it's often not the flow that causes the discomfort, but rather the heat and the moisture that is being applied into their nasal passages. The harness itself is very comfortable to wear, as is the nasal cannula, and the patient is able to move fairly freely with it applied. Like non-invasive ventilation, this is not something strap on and walk away. It takes time, and it's something that we probably do not have enough of at the moment. but it does take time. There needs to be a very clear briefing to the patient as to what to expect. You need to then apply the machine and starting max and then working down as fast as possible with regards to FiO2. And once you're into lower FiO2s, you would then be able to wean down the flow. But as a rule of thumb, take it up as high as you can, take your FiO2 as high as you can, and then aim at decreasing that FiO2 as soon as possible. And the question then becomes, it's quite easy when they're doing better, the SATs improve, the work of breathing is improved, and you generally find that the patients respond quite favorably to it if they are going to. The difficulty comes is that how do you make the assessment that they are not being successful on the high flow? And I think that's often the most difficult decision is, do you persist or do you stop and try something else? Now, probably the beginning of last year, the ROX index was established and verified with regards to hypoxic pneumonias. It has not been verified within the use of COVID-specific pneumonias, but certainly in other hypoxic pneumonias. And it's something that you can do at the bedside, in that you simply look at what the patient's saturations are, you divide that by the FiO2 that the patient is on, and then you divide that number that you've just created by the respiratory rate. And if you've got a number that's anything greater than about the literature says 4.88, but if you use a number of 5 in your mind, if the number's greater than 5, you're doing well. If it's less than that, you're not. And in all likelihood, you are probably going to look at perhaps failing in that particular in that particular patient. So another way to look at it is from a time-based perspective when you're looking at that ROX index, and you're really wanting to see an improvement of that patient's ROX index over time. The initial literature stated 4.88. There have been some other studies that have shown that stepwise approach, looking at anything between 2.85 at about 2 hours, going up to 3.5 at 6 hours, and then getting to that 4.88 at 12 hours. And that really gives you an indication as to whether you are succeeding or not. So high flow is really easy to manage. It's really easy to apply. It's really easy to make decisions with regards to, is the patient getting better or are they not? And to that extent, and it is variable between facilities, we've been applying it in general wards, so outside of critical care environments. So both at the Tygerberg facility and at Grooteskier, and at the facility I'm based at New Somerset, it is being applied in general wards, but in the areas that have been carefully designated, and also to ensure the safety of the staff working in those areas. I'm going to pause there for a moment and just check if there are any questions with regards to the high flow nasal cannulae.
Hi, Roger, it's David.
Hello, David.
Just in terms of tolerance of this high flow thing on their nose, are you needing to give them anything to help them settle, or are they accepting it quite happily?
So we generally find that because it's tolerated better than a non-rebreather mask, and I think it's because it is not that something being clamped onto their faces. We have not had to give any kind of sedation, and we actually avoid giving sedation on the high flow nasal. There are some patients that request a sleeping tablet at night because they are generally prone, and it's more the discomfort of being prone for some of the patient rather than the difficulty of the high flow nasal. But we've not had to give any sedation, and if you do, then a very, very light, probably benzodiazepine would be completely adequate. I see Juliana has asked, what does the ROX index entail? The ROX index is simply a calculation. You take the patient saturation, so to give an example of 80%, you would then divide into that the FiO2. So if they are on an FiO2 of 100%, you would divide it by 1. So that would then give you 80. You then divide that by the respiratory rate, and you would look to see the number that you've got left. So that gives you the ROX index, and that's what we are working with. I don't know if that answers your question. So the question from Mohammed was, what would the next step be for the 70-year-old if she didn't respond to the high flow? If I can come back to that, because that would be the next topic that I would like to speak of this evening. Otherwise, I don't know if there are any specific questions that people would like to voice. So I'm seeing, I found that it's not effective in patients. Sorry, the comment is from Eba Collip to say that they don't find it effective in patients who are mouth breathers. Should patients keep their mouth closed? So it's an interesting debate, and the debate comes around the PEEP that is actually generated by the high flow. And in order to generate the PEEP, the mouth does have to be closed. We do find that even in obligate mouth breathers, because of the high flow oxygen going down the nasopharynx, we do see an increase in the tolerance of these patients, and they do fairly well. But if they are PEEP dependent, they generally are not going to do well on the high flow if they are open mouthers or obligate mouth breathers. I don't know if anyone else has hands up. Okay, Ridwan Mohammed has asked, have any facilities run into problems with oxygen supply? Yes, we did, as a result of the high flow units, and could this become a problem? So absolutely. So the facility I'm based is a relatively ancient facility based in the Cape Town waterfront. And early on, we ran into difficulties with the oxygen reticulation. So this was both from the amount of flow that we were able to get into the facility, but also with regards to the vaporization of the liquid oxygen from the tanks. And to the extent that we started getting pressure alarms throughout our systems when we started high flow. We went through a re-reticulation of the oxygen lines. We also installed a much larger vaporizer. So we were running on a 4-vein vaporizer. We are now running on a 20-vein vaporizer. And we are going through about 2.5 tons of liquid oxygen every 2 days. So there are significant demands from an oxygen perspective. And it is dependent not only on the size of the vaporizer and the size of your liquid oxygen tank, but also the diameter of the reticulation that is coming into the facility, particularly if you are running a lot of other oxygen areas on high flows. So if you think about it, most of the time you're not running every single oxygen port in your facility with a double splitter, and each of them running between 10 and 15 liters per minute. So yes, you can run into oxygen difficulties, and it's something that you need to keep a close eye on. We had to pause the rollout of the high flow in our facility until we were able to rectify that. It isn't that well, it's not efficient with regards to oxygen usage, but it's certainly more efficient use of beds, in that the patients do better in them and they are there for a shorter period. The next question is from Paul Smith. How soon after starting the high flow nasal oxygen would you like to be able to reduce the FiO2? So as soon as possible, and ideally you'd like to be to about 60% within 24 hours. So don't fiddle with the flow initially, leave the flow up and then decrease your FiO2. And ideally you would like to be below 60% within 24 hours. There are some patients who just, are a bit slow in responding, but the aim, that would be the aim. Mohammed Sarvan has asked, is high saturation oxygen toxic to the lungs, or is there long-term damage? So we do know that high FiO2s are toxic. It's through the production of superoxide radicals, and these can cause a chemotoxicity to the alveolar tissue. In animal studies, this has been demonstrated in anything up to 2 hours of 100% FiO2. But if we go back to the ArtsNet recommendations, that was where the recommendation of below 60% within 24 hours. Brent Prim has asked, how can we feed patients on high flow, and what is the aspiration, and what aspiration risk do we run? So yes, we are feeding patients. They are eating, they are drinking on the high flow. The important thing there is that they need to have a level of consciousness that they are able to eat and drink. And we are not finding any difficulty or aspiration risk with that at all, to be honest. The only time that we have run into difficulty is where the patients have had a diminished level of consciousness, and that is where you do run an aspiration risk. I'm not sure if there are any other questions. Okay, so from Vanessa Aithaler, are you also adding glutathione to your treatment plan for these high oxygen administration? I'm assuming it's you talking with regards to the risk of the superoxide radicals. We are not at this stage, and it's mainly because these patients majoritively are being managed outside of a critical care environment. So not routinely. The next question from Ishan Rambali is, how do we reduce the FiO2 based on the PaO2 or oxygen sats? So again, you've got to look at how you are managing these patients and where you are managing these patients. So with us managing them in a general ward, we are doing it on oxygen saturations rather than on blood gases. And for those patients, we are doing intermittent blood gases, perhaps once every 12 hours. And that's as they do not have arterial lines in situ. For those that are being managed in critical care environments where you do have arterial blood sampling, you can run them based on the blood gas specifically, but we are doing it based on oxygen saturation, respiratory rate, and work of breathing as the indicators. Can I just get an idea with regards to, have any of you had exposure or experience with the high flow nasal oxygen at all? Okay, so I've got 2 yeses, no, 3 yeses, 2 no's. So yes, from a PEDS perspective, which I think a lot of us learned high flow from PEDS. I see Bloemfontein is using it again, pediatrics popping its head up. So just looking across the answers there, we've got probably about half and half with regards to using it and not using it. And you'll see that it is used quite extensively, particularly in the PUI and COVID areas at present, just in an attempt to decrease the need for other forms of ventilation, whether you're looking at non-invasive or with regards to invasive ventilation and intubation. So thank you to who put the poll up. I see that we're looking at about 1/3 have used the high flow and 2/3 have not. It is something that is a little scary at first. And what I would actually suggest, the price of the circuits is often difficult, is to try it on yourself. It's very easy then to explain to a patient what they are going to feel and what to expect when you place the patients onto it. Right, the other questions, have you used high flow with active cyclic breathing and breath stacking, and did it have any positive impact? That's from Layla Adam. So we do use it in active cycling, and we find that works quite well. Admittedly, the breath stacking is often difficult to achieve in these patients, and it's really for two things. They are generally not only hypoxic, but also hypercarbic. And so trying to get them to do the breath stacking is often difficult. So from that perspective, I don't have any experience in that. So Juliana de Kock has asked, what HB do you accept in ICU? So that's a kind of question that when we teach our registrars to answer that in an exam, it would be, it depends. And so, yes, it absolutely does depend. Generally, we're looking at looking at the comorbidities, and a lot of the patients that that are needing this kind of work do have significant comorbidities. And so we generally run them on towards the higher range, so using 10 as a minimum. If you're looking at the balance between oxygen delivery and rheology, in a general patient, you can probably look at 7, but in a patient with ischemic heart disease or a vasculopathy, we should probably be looking at higher. And if we look at the majority of the patients that are needing the high flow nasal oxygen, they tend to be the hypertensive diabetic, so with significant cardiovascular disease, and should probably be running them at 10 as a minimum. Jay Manny's asked for the price of the machine. It is variable, depending on which model, or which manufacturer you go with. It's probably the biggest thing that, as ventilators go, they are relatively cheap, but the circuits are expensive, and they range anything between 800 Rand and 3,500 Rand. It's probably less of a worry from the private sector perspective, in that you've got a usage-based costing model. From our side, it's quite a significant impact on a budget with regards to that kind of costing. Mandy Token, good afternoon, Mandy. Can you explain that for others on the site? Have you used high flow nasal oxygen with active cyclic breathing and breath stacking, and did it have any positive impact? Okay, so
Mandy,
hi, Mandy, go for it.
Not everyone may understand that, because this is a session for non-ICU clinicians. So if perhaps you could explain that to some of the non-ICU clinicians on the site, please.
Sure. So if you're looking at active cycling of breathing, what we're trying to achieve there is to run through not just tidal volume ventilation. So understanding that this is for a patient who's awake and breathing spontaneously. So we normally breathe at a tidal volume. And so with active breathing, what you're trying to do is to saturate your residual volume as much as possible, and to go through that good old-fashioned physiological curve running from your inspiratory reserve volume right down into your expiratory reserve volume. So for want of a better term, it is deep breathing in cycles. The difficulty often is for the patient to be able to do it, they need to be fully aware, and often they need to try to slow their respiratory rate down in order to achieve it. And often in the early phases, that's not all that easy, and it's something that you do need to persist with. So it is cycling between your inspiratory reserve volume to your expiratory reserve volume. So big breaths, as slowing them down a little bit, and then you are varying that between the deep breaths and then your normal tidal breaths. So that's the approach that we have, the active cycling. Breath stacking is it's an attempt to improve PEEP and to assist with regards to recruitment. We found that it does work quite well in the prone position particularly. And that is where you're wanting to take the patient to take a breath, hold it, take another breath, hold it, take another breath, and then breathe out. And what you're trying to do is to increase the intrinsic PEEP that is retained within the alveolus to try and assist with regards to recruitment. I don't know if that's clear, Mandy.
Yeah, Roger, for me, yeah. For the others on site, are you all right with that?
I see Steve Cornish has asked what is breath stacking. I'm hoping I've clarified that. Looks like everyone is clear with that. So again, probably the biggest difficulty here is that these patients are profoundly hypoxic and they are hypercarbic, and so often they're not all that easy to cooperate with you in those early stages. And so just getting them settled onto the high flow is a good start. And then once they are comfortable that this is doing good for them, you can then step it up. And that's what we found has been very useful. The next question is part of the respiratory physiotherapy treatment. Absolutely. And it's something that I have newfound respect for the physiotherapists working in our units. They do amazing work with these patients, and they don't take nonsense, which is even better. Getting these patients not only to prone when they really don't want to, but also to do the respiratory cycling. I see Nsandla Radebe has said, highly recommend the active breathing techniques by physiotherapists. Yeah, completely agree. So in a simplistic way, you strap it onto the patient, crank it up as high as it can go, and then pull back. Pull back on your FiO2 first. And once you're onto a room air type of saturation, so going into the range of 30 to 35%, you can then start looking at decreasing the flow. But from a start perspective, crank it up as high as it goes, high FiO2, get your FiO2 down below 60% within 24 hours if all possible, and don't forget to continuously checking the temperature and the humidification system. And then finally, don't be afraid to say this isn't working, we need to do something more. And so at that point, I think if people are happy, I'd like to move on to the use of non-invasive ventilation. So again, there were big concerns early on with regards to the aerosolization. Sorry, I see there's a last minute question with regards to the high flow. Does a history of CPOD influence decision-making regarding the high flow nasal oxygen. Someone taps the way I do. So, so if you're looking at chronic pulmonary disease, we actually find that they do quite well on the high flow nasal. And it's probably because of the small amount of PEEP that is also being generated. And you see with these patients is that they do like a little bit of PEEP. It decreases their work of breathing, it re-recruits them, and they often do better. All right, so moving then on to the non-invasive ventilation. And this really used to be seen as a bridging technique to try and get a patient to make it to a point of intubation and invasive ventilation. But we've really seen the development of non-invasive ventilation for a great number of indications, whether it's from cardiac failure, used with caution in acute asthma, and then certainly for patients with COPD. What we've never really used it before is with regards to patients with pneumonia, particularly for a long term. And it was really because we figured, well, if they are needing that kind of ventilatory support, then we probably should be looking at intubating them. So non-invasive ventilation is applied either by a face mask or it can be applied by an inflatable space helmet, for want of a better term. And it is able to deliver not only oxygen, but pressure to these patients. And you can also generate a rate or support a rate. Generally in the wake patient, we are using this in either just a plain CPAP mode or in a pressure support mode or in a BiPAP mode. So it starts running into acronyms, and when we start getting into the 2-letter acronyms, 3-letter acronyms, and multi-letter acronyms is when people start losing interest and falling off the wagon. I have to say that the majority of these cases we've been using is just straight CPAP, and we found that these patients do incredibly well. There are some that we are needing to add a degree of pressure support onto. Now, just like high flow nasal oxygen, CPAP is a learning opportunity, not only for yourself, but also for the patient. And you'll find that the patients who perhaps have had COPD and they've had NIV before, they are very familiar with it, not only with what to expect, but also how good they feel on it. And we've had some situations recently where we were trying to transition a patient off of the CPAP and the non-invasive ventilation back onto the high flow nasal. And she would sit on the high flow nasal for about 6 hours and then say, you know what, time to go back onto the CPAP, I'm tired. And that is really just the indication of how successful it can be. With regards to these patients, it takes time. The worst thing that you can do is take the non-invasive mask, clamp it onto the patient's face, crank up the pressure and walk away. You will fail dramatically. And what we found the best thing to do is to give the mask to the patient and ask them to hold it on. It helps them with their claustrophobia because they are in control. And once they start to feel that they are getting support is when you can start applying the harnesses. Now, there are many manufacturers producing CPAP masks, and they are really trying to ensure that you don't get pressure sores and that they are as comfortable for the patients and that they are going to be on for a long time. You need to ensure that the mask is well fitting, that it goes across the bridge of the nose and to the jawline and is able to extend wide enough that the mask in a non-purse position is not going to create a leak. The other important thing is that non-invasive ventilation is designed to leak. So please do not clamp the mask and tie it on so tight that there's absolutely no leak. They are designed to leak a little bit. You just don't want large amounts of leak, because the tighter you pull those straps, the more likely you are to end up with pressure sores. And we've seen that in some patients who've been on CPAP for long periods of time, ending up with pressure sores on their faces from the non-invasive masks. So you want to place the mask on, give it to the patient, let them hold it so that they can feel the improvement that it creates, and talk them through it. And often the thing to do there is to breathe with them. We found that that is quite successful. And it's simple things like take a deep breath in, hold it, breathe out, and repeat, obviously, indefinitely. So get them to understand what you're trying to do, that they need to breathe as slowly as possible in order to get the greatest benefit, and that they need to feel as comfortable as possible in the headgear that goes along with the non-invasive mask. So that's the application of the mask itself. And then comes the fun and games with regards to tickling the ventilator in order to achieve it. Now, the majority of the modern ventilators will have a non-invasive mode, and you do need to specifically select it when you turn the ventilator on, or when you are selecting the mode, in that you can offer CPAP to an intubated patient, and you can offer it to a non-intubated patient. And it really comes down to the amount of leak that the system is able to tolerate before alarming. With regards to, so make that sure that you've selected the non-invasive mode. And here we do see a contrast to what I said to you with regards to the high flow nasal oxygen. In CPAP, you want to start low and you want to go up fairly slowly as the patient tolerates. So it's no good cranking it up and slapping it onto the patient's face and say, sit down and take it. It's something that you need to start low and go slow. We suggest starting at a CPAP in the range of about 4 or 5, and then going up fairly slowly until you get to an optimal PEEP. Now, reaching that optimal PEEP is, again, it depends type of answer, and it is very dependent on the patient. And it's also very dependent on the patient at the point in time that they are in their disease, and that it may vary within the same patient from time to time. What I can say from the exposure we've had here is that they don't seem to enjoy the higher PEEP that we have seen benefiting patients with general ARDS. And so you're looking at most of the time in the range of PEEPs at a maximum of 14, to be honest. Yes, you can crank it up higher, but the patients do not seem to enjoy it. And this is contrary to what we've seen in other forms of ARDS and pneumonia. So start low, go slow, sit with the patient's bedside. And what I always say to the staff that I work with is that when you're putting a patient onto NIV, take a cup of tea with you. I'm not saying do that in a COVID environment, because it would mean you'd have to drop your mask. But that's the concept, is that you're going to be there for a while. And it's something that here both the medical and the nursing staff need to work together with. It takes a lot of reassurance for the patients so that they are able to tolerate what they are going to be enduring. Once you have them settled on it, they generally are the ones that will ask for it. So that is often the success of it. So from an FiO2 perspective, the same concept. So start high, take them down as soon as you possibly can, and going in the opposite direction with the PEEP. If you run into difficulty with regards to CO2, so they're becoming hypocarbic, but their oxygenation has improved, you can consider giving them a little bit of pressure support in order to assist their tidal volumes. but that starts getting a little bit tricky with regards to how much and when. So from a simple CPAP perspective, you are keeping your inspiratory pressures and your expiratory pressures at the same level. You apply the mask, get them to hold it initially. You want to have a tight fit, but not too tight. You should still be able to blanch skin under the mask, and then gently go up with the CPAP until you are able to achieve the saturations that you want. That optimal PEEP that I spoke of before is really, it is going up on your PEEP until you no longer get an improvement in either your saturations, if you're measuring on a SpO2, or on your blood gas parameters, and then coming back down again until it starts to drop and then going just above it. If you do have ventilatory graphics on your ventilator, you can look at the lower inflection point on the hysteresis curve. And for want of a better term, it's when that lung inflation curve starts going up. It's really where you want to have your PEEP sitting. It decreases the work of breathing, decreases the amount of atelectasis that occurs. And so you end up with better oxygenation and a better balance between oxygen demand and oxygen supply. I think I'm just going to pause there because I see that there are a couple of questions that have come up. Firstly, from Shani Johnson, are there different sized masks? I find the mask struggles to place well on morbidly obese patients, e.g. BMIs of 80, and in terms of leakage, is the farting noise the leakage? So that's a very good way of putting it, I must say. So yes, there are a variety of mask sizes and there are a variety of mask shapes, and you do need to find the one that is going to be best for the patient. And often it is a bit of trial and error to find the best mask for the patient. With regards to the leakage, the farting noise probably means that you don't have enough tension in your mask. You should hear, I suppose you could say, to use your analogy, the silent but violent type of noise would be more in keeping with the leakage that you want. So the little rather than the large farting noise as you've described. Are there any other questions at this point? So Juliana de Kock has asked, do you set a rate? And I see Shani has corrected me that it's not a, okay, thank you very much, Shani. With regards, Juliana, from a rate perspective, so you do need to look at it from a patient perspective here. Often if you are selecting a rate, you may worsen the scenario. So selecting a rate would then take you into either a full non-invasive ventilation, or where you may be selecting a rate is in the BiPAP environment. And what you're doing in BiPAP is that you are cycling between two levels of PEEP. And what you're doing is setting the cycle rate between those two levels of PEEP. So in that situation, you may want to select a rate, but ordinarily, if you've got a patient on CPAP, we wouldn't be putting them on a rate. We want to be able to measure what their rate is so that we can see how they are responding, because they should be able to decrease their own rate as they respond, that is, if it is of benefit to them. So we don't generally set a rate if we've got a patient on CPAP. If the patient is needing pressure support, we may give them a rate, but that's generally where we are looking at a BiPAP scenario with the cycling between the upper and lower PEEPs. So again, just as a simplistic type of approach, from a CPAP perspective, give them the mask, let them apply it, start low, go slow from a pressure perspective, from an FiO2, start high and drop as fast as you can to get that FiO2 below 60. Apply the mask firmly, but not too tight. You still want to be able to get skin blanching under the mask. And I cannot overemphasize the need to explain to the patient and literally hold their hands while you are doing it. When I say hold their hands, I don't mean hold their hands away from trying to pull the mask off. I meant it more figuratively. So Brent Prim has asked, which starting PEEP would you recommend, and what interval would you titrate up at a minimum? So from a starting PEEP, you can actually start at 0 if they are not all that confident that they are going to tolerate the mask. I generally start at between 2 and 4, looking at getting them settled onto it, and then going up about 2 centimeters of water every 5 to 10 minutes until we are able to get them to where we are wanting them to be. So I generally look at settling the patient onto the NIV or CPAP over the course of about 15 to 30 minutes. As I said, take your cup of coffee with you, but don't drink it there because you'd have to take your mask off. Again, if we could get an idea from everybody with regards to experience with CPAP, either from a non-invasive perspective or even in an invasively ventilated individual. Does anyone have experience with CPAP? Or may even have used nasal CPAP at home? It's interesting, seems to be a lot more experience with regards. Sorry, I'm just chuckling there. Thank you for the laugh, Vanessa. I see Vanessa very clearly said yes and then had to stipulate at work. So thanks for that, Vanessa. So it seems that people have been using a lot more, seem to be a lot more familiar with regards to CPAP rather than the high flow nasal. A question from Heinrich Krimsel. Have you used the full face diving mask slightly converted? So are you talking from the PPE perspective, or are you talking from the application? Because there are some commercial devices that are available, which are the full face masks. It's often a little bit better tolerated by the individuals, but you often run into difficulties with seals, particularly when you're trying to prone them, because it's got a larger footprint and you're needing to move the head quite far in order to prone them comfortably. The next question is, great challenge finding a balance between adequate PEEP and pressures in the light of stomach inflation and further FRC reduction. Completely agree. And we often see this in patients with raised BMIs. So they often will swallow air if you've got the PEEP up quite high, and that will often splint the diaphragm. Again, that worsens atelectasis and you end up with a loss of oxygen ability, so not great. I must admit, when I was doing my ICU training, the non-invasive was often seen as a stepwise procedure, that it was to see if they could do it while you got ready for an intubation. And it was really in the realm of emergency medicine that we've seen the scope of non-invasive ventilation, and particularly CPAP, particularly in your cardiac failures, pulmonary edemas, COPDs, asthmatics, really working quite well. It's unusual to have applied it in a pneumonia patient, but as I mentioned before, it has been quite a good technique. Mr. Caesar, Noting the long waiting times for EMS, do you think there's room for high-flow nasal cannulae at the CHC level while clients are waiting for transfer, and what is the minimum time to be on it? Samantha, I have seen your question. I will come back to, so you just had a comment. Sorry, Samantha. It's good to see you again. I haven't spoken in a while. Just with regards to the use, there's two aspects that you need to look at with the high-flow nasal at remote facilities. Is firstly, a lot of those facilities operate on oxygen bank rather than liquid oxygen tanks and VIEs. And so the amount of oxygen consumed is problematic in that you often are not able to achieve it. And the other difficulty is that it's very difficult to move adult patients on high-flow nasal oxygen, and it comes down to the amount, again, of oxygen that is required. There's also the potential risk of aerosolization within a very small environment, but again, with adequate PPE, that should not be a factor. So the biggest issue is with regards to the amount of oxygen consumed during the transfer. And as you know, we've advised that we would not be offering high-flow nasal at far-flung district facilities. And I know you're based at the Dunoon facility, which is in well, one of the facilities referring into my hospital. And it's not something that we would be looking at present, but that's from a Western Cape policy perspective. I can't comment from a general perspective, but from a theoretical perspective, the limitations are in the amount of oxygen required to move them. Your second question with regards to how long these patients are on the high-flow nasal, again, it depends. You see patients responding well in 3 to 4 days, and some will need to be on it for anything up to 10 days. In that it is often a very slow weaning process from a flow perspective. So it's not something that you would want to have at a CHC, for instance, because they would generally be there for quite a protracted period if they were to stay on it there. Eva Collip, just to confirm, the high-flow nasal oxygen and CPAP considered high aerosolization and should be used in negative pressure environment. So again, I think I mentioned this a little while ago. There was a trial that was published about 3 weeks ago, which demonstrated that the potential for aerosolization in high-flow nasal oxygen is probably less of a factor than we initially thought. And routine ventilation was considered to be adequate. That being said, I've spent a lot of time putting extraction ducting into the areas where we are doing the high flow nasal oxygen at my facility, and it was really to just improve the ventilation of those areas. In an ideal world where you were operating these in a very closed environment, absolutely. But the risk for aerosolization is probably not as great as we thought it was. Steve Cornish, go for it.
I just want to say it has just gone 7:05. So just wary of the time in case you're going to leave, but happy for you to continue if you have the time available as well.
I apologize. I think I'd gotten a little excited. I'll take the last question from Steve and then do a final round. I apologize. I didn't realize it was already an hour. I hope it has been useful. Steve Cornish has asked, what percentage of patients after recovery are permanently dependent on supplemental oxygen? It's difficult to extend in that if we are looking at this from a COVID disease, I think we are starting to see that there are quite a large number of patients who will require home oxygen. There are a large number that will have cardiac disease following the COVID infection. That being said, we are seeing lots of people who are not, and they need that oxygen bridge for a relatively short period. but they do incredibly well thereafter. So it would be a thumb suck at this stage with regards to how many, and it would also probably be dependent on the severity of disease rather than the techniques that have been applied. It's not something that I can answer that easily, Steve, I'm sorry. Are there any other burning issues or any other questions? If not, I hope this has been useful, and I'll hand back to the chair, and thank you to Mandy for the comments.
Thanks so much, Prof. I really, really appreciate it. I think I'm very rusty in my clinical knowledge, very far from clinical medicine, so thank you. That was a really great overview of everything. David and Mandy, I'm not sure if you want to have closing comments.
I think I do, Roger. You know, whenever we ask you to do something, it always is amazing, and there's just so much learning. And I think it was very helpful for a lot of people. And to all the colleagues who have also added comments and asked comments. And my best comment is having Roger Dickerson talk on a national webinar on farting. So I really appreciate it. And I'll never be able to listen to a patient leaking ever again without thinking of you, Roger. And that is CPAP leaking, by the way. Or
I'm glad you made that clear, Mandy.
I really appreciate it. It's been a great series, and we'll have you on again if you don't mind, Roger, because it's a rolling series. So I'm sure there will be, in a week's time or 2 weeks' time, we'll have you on again. We really appreciate it. Are there any other questions, David, from you or anyone else online? Just, can I make a comment in terms of the oxygen? And I didn't want to disturb you when you were talking. We're currently electronically monitoring our oxygen levels in our hospitals, and we can definitely see the hospitals that are running lots of high flow nasal and come very, very dangerously close to reaching the threshold when your oxygen is starting to become very low. And so I think monitoring of oxygen, I would not start it in any facility where you don't have any active monitoring of oxygen. And then the other thing which I think is also important is stop wasting the oxygen. When the patient takes their nasal cannula off to go to the bathroom or to eat or whatever, they need to actually switch it off, because otherwise you are bleeding oxygen.
Mandy, I completely agree, and it's something that I did quite early on at our hospital. Is that I changed the telemetry on our bulk store from an oxygen perspective. So it used to trigger at 1/4, and we now trigger it at half. So when the bulk tank reaches half, it triggers the oxygen delivery. And we're getting deliveries every second day. So it's a very important thing. And oxygen is not as easily available at the moment as we used to think.
Roger, somebody asked what happens when there's load shedding. Well, at least the fan gets switched off and it no longer hits you in the face. But in terms of load shedding, your equipment should be plugged into your generator. And if it's plugged into generator plugs, then there shouldn't be a problem. And oxygen is not dependent on load shedding either, unless the only thing that might be is air, dependent on your pumps. So there should be no problem with load shedding if you actually have your equipment plugged into your generator plugs, your red plugs, emergency plugs.
Yeah, completely.
Thanks, Roger. I really appreciate it. David?
Great.
No, nothing extra other than thank you so much, Roger. That was amazing.
Awesome. Thank you very much, everybody. Good luck. Stay safe and have fun. Go well.
Thanks so much, everybody. Just one final comment for everybody. The recordings will be made available through Netcare's YouTube page. And a reminder to please just share the link with everybody else to register and invite more people to the session. I hope it does prove useful, and I would like to share with more and more people. Thank you. Have a good evening. We'll see you tomorrow night.